Good morning, everyone. I'm John Ravitz, the Executive Vice President and Chief Operating Officer for the Business Council of Westchester. On behalf of Marcia Gordon, our President and CEO, and George Lentz, the Chair of our Government Action Council, we want to welcome everyone to this webinar in which we will be discussing the New York Health Act and doing an analysis of the new version of this legislation, which has been known as the Single Payer Bill in New York. As many of you know, the Business Council of Westchester has opposed this bill in the past. We've opposed it because we were very concerned about the fiscal ramifications that this bill would have on New York, especially as we continue to reemerge from the pandemic, and the impact it would have on businesses in terms of more burden and obstacles that would be in their way. We have a good panel of speakers who really have spent a great deal of their time and their careers looking at this legislation and really beginning to ask the tough questions. And so we thought it was important to bring that to the members of the BCW this morning. We're also very lucky that we have a leader within our organization who also chairs our board. Jamie Schutzer is a senior partner at JDM Benefits, an Alera Group company, and he's also the co-legislative chair of the New York State National Association of Benefit Insurance Professionals. Jamie has been a leader for us on health insurance legislation when the Affordable Care Act just was introduced and the New York Health Exchange was being built. Jamie and I went on a roadshow all over Westchester County to begin to educate businesses of all sizes of what this impact would be. And we've leaned very heavily on Jamie as we continue to look at this legislation and other legislations that deal with healthcare insurance for his guidance. But I'd like to turn it over for Jamie to say a few words.
Thanks, John. Good morning, everyone. Happy to be here. And like John said, my daytime job outside of being the board chair of the Business Council of Westchester is an employee benefit consultant. I work with employers of all sizes and in a unique position because where we sit, we're involved with obviously the employer community, we're involved with the insurance community, we're involved with the provider community. So we kind of sit in the middle, touching all the areas around healthcare and health insurance. And it gives us that unique perspective. And, I know that this bill, the New York Health Act, has been hanging around for, well, certainly before I've been in the industry, but many, many, many years. And about 6 years ago or so, it came out of the blue, it seems like, and was passed in the New York State Assembly. And at that point, everyone was in a panic. And, well, what does it mean? What are the costs? How is it going to impact employers? Is it well thought out? And at that time, we're also on the heels that John mentioned, the ACA was being fully implemented. Our uninsured rate decreased to a number of like 4 or 5% here in New York, which was amazing to get all those people covered. And it was kind of like things were moving along, and this came out of the blue, and it was like, whoa, hold on. And I could just tell you from my standpoint, and I'm going to let the experts, I know both these gentlemen, Bill and Lev, and they've been up in Albany for many, many years, and both focus on a whole host of issues, including healthcare. But, the few things that I saw right off the bat that were going to be problematic, beside the cost, which again, the Lev and Bill will get into, would be if you were a self-funded health plan. And, a lot of larger organizations choose to go that way. And this would not necessarily be a mandate on them. But if you had this progressive payroll tax and you had to continue to pay your health insurance, what happens there? Another one was network access. So this is something that was specifically targeting for New York. We live in Westchester County. I see doctors, my family sees doctors, and probably many of you see doctors also in Connecticut. Right. So we're always focused on our networks and having national access. So how are you going to address for that? If you're an employer based here in New York and you had employees that were in other states, how is that going to be addressed? Retirees is another thing, which is a big issue. And maybe Bill and Lev will talk more about that and what deals might be cut to appease, retiree classes, doctors, hospitals, reimbursements. Right now, There's really no information on how that is going to work out, what those amounts are going to be. What we do know is that in the commercial market, including employer-sponsored coverage, there is a much higher reimbursement than you would see on a Medicaid or Medicare, and that absolutely helps the provider community. So where was that going to go? And then certainly the costs, and I think that's going to be a big part of Bill and Lev's presentation. So again, I'm excited to learn about what's going on up there. They're the experts. So thank you very much, John.
Jamie, thank you very much as well. As Jamie mentioned, we wanted to bring to this webinar, folks who really not only have been working to get a handle on what the ramifications would be for this bill, but really to flush it out so that people can understand again what the consequences would be if this bill were to pass. And Jamie's right. This bill was usually a one house bill in the Assembly majority. When I was in the Assembly, I was the ranker on the Health Committee in 1994, when then Chair Dick Gottfried brought this bill to the committee, and we started asking Dick the same questions that we're still asking legislators. How would New York State be able to afford this, and what would be the fiscal ramifications for this as well? So today's two guests are ones who can and have continued to lead that charge. Bill Hammond is a senior fellow for health policy at the Empire Center. Bill, which is an Albany-based think tank focused in New York State. Bill has authored reports analyzing New York's response to the coronavirus pandemic, tracking the state's surging Medicaid costs, and critiquing a proposed state-run single-payer healthcare system, among other topics. Before joining the Empire Center in 2016, Bill spent almost 3 decades in newspaper journalism, most recently as a columnist and editorial member at the New York Daily News from 2005 to 2015. Before joining the Daily News, Bill wrote for the New York Sun, the Daily Gazette of Schenectady, and the Post-Star of Glen Falls. His work has also appeared in the Wall Street Journal, Politico New York, the New York Post, City and State, the Albany Times-Union, the Buffalo News, and the 74. Lev Ginsburg is the executive director for the New York State Conference of Blue Cross Blue Shield, and he's also a partner with Hinman Straub. And he advocates on behalf of the New York Blue Cross and Blue Shield plans on policy decisions to ensure that affordable, high-quality health insurance coverage and healthcare services are afforded to all New Yorkers. Prior to joining Hinman Straub, Lev served as general counsel to the Business Council of New York State. During his nearly 11 years with the Business Council, he served in a variety of roles, including as Senior Director of Government Affairs, and he served as the attorney and staff supervisor with the former governor's Office of Regulatory Reform. Lev, Bill, thank you so much for your ongoing work in this area. You both have been good friends to the Business Council of Westchester, and we appreciate you spending time with us this morning. Lev, I'm going to turn it over to you. Before we start, if people do have questions at the end, please put them in, or during the presentation, put them in the Q&A box. We'll come back on for a few minutes to try to answer some of those questions. This session is also being recorded, as it's out live now on our Facebook page as well, but it is going to be recorded and it will be on our business resource page. So for folks who have either missed part of it or want to come back and look at it or share it with some of their colleagues, please feel free to do so on our website, which is www.thebcw.org. Lev, I'm going to turn it over to you, and you and Bill will take over, and I'll come back on to, as I said, take some questions.
Fantastic. Thanks, John. And thank you, Marcia and Jamie and Amanda. Thank you for having us today to discuss a topic that we've discussed before, and we feel a need to continue to discuss it. The single payer, the New York Health Plan, the single payer plan for New York State, which was reintroduced this summer by Senator Rivera as S7590, if you're taking notes, chair of the Senate Health Committee, and the chair of the Assembly Health Committee, Assemblywoman Paulin, as A7897. It's a bill that has a significantly long history, as John alluded to. And thank you, John and Jamie. You really sort of outlined our discussions for today. I think what Bill and I are going to do is just sort of fill in the spaces in between. It's interesting to take a look at this bill, and it has changed a bit. The new iteration, which we saw come out this summer, and Bill will get into the specifics, adds a few tweaks and a few changes, but ultimately it's very similar to bills that we've seen before. But this has been a bill that has evolved year after year as more benefits essentially are added to it without a tremendous amount of specificity being added to it since 1991, when then Assemblyman Dick Gottfried, who was eventually the chair of the Health Committee in the Assembly for about 3 decades, introduced it in 91, and the Assembly immediately passed it, actually, in 92. There was a hiatus on them taking it up and passing it until the mid 2010s. It passed in 2015, 2016, 2017, and 2018 in the Assembly. So just a couple of quick notes about sort of where it came from and the impetus. And Jamie had sort of alluded to the fact that back in the early 90s, there were about, on average, about 15% of New Yorkers that were uninsured. And it was a fluctuating number, and it sort of depended on whether you were talking about those above or under 18 years old. We had taken measures already to insure some children. So there was a lower number of under 18s and a higher number of 18s. But on average, about 15% of New Yorkers were uninsured. And that really was the spoken impetus for this plan. And just so we can be clear, we're not, we want to differentiate the difference between universal coverage and a single payer system. And universal coverage simply means that all New Yorkers or all people in any given jurisdiction have health care and have health insurance in some form of coverage. We are very much in favor of universal coverage. This is something that I think all of us on this panel and all of us on this call want to see and have been working towards in our various capacities. There are a lot of ways to get there, and I think that what we'll highlight today is that this plan is certainly not the best way to do it. In fact, since, as Jamie alluded to, since that 1991 time, we saw the institution of the ACA, what some people call Obamacare, which in part, among other things, helped bring the coverage in New York up to about 95%, maybe even a little better. The numbers post-COVID have been a little bit hard to sort of get all of the data yet, but we're working at about 5% of the state of New York that is uninsured. It's too much, that's for sure, but we're talking about 800,000 people that we need to work for coverage. As I mentioned, this bill passed immediately, and then it didn't pass for many, many years. And then it passed again in the mid 2010s. Sort of some of the political realities that existed at the time, of course, were that we had a split government. We had Democratic control of the Assembly, which we continue to have, and we had Republican control of the Senate. And there was very little risk when the Assembly passed this bill that the Senate was ever going to take it up. So I think that there was a bit more freedom in their action, I think, because it was more of a statement than it was anything else. When the Senate flipped later in the 2010s or the 2010s, we saw sort of an immediate change, not just on this bill, but a lot of bills, frankly, that were really economically devastating, that the Assembly used to pass willy-nilly, knowing the Senate would never take them up. And now we've sort of seen an actual shift where the Assembly has held back on a number of bills simply because they are certain that the Senate would take action and pass them. So on this particular bill, the sort of the politics that exists today, I think that there's a really significant chance that the Senate could pass this bill. Gustavo Rivera, the chair of the Health Committee, this is his baby. This is what he works for all the time to get passed. And so as we go through the conversation, it's important to remember, I think that Bill would agree with me, that we live in a world where, we don't quite know the status of this bill. I like to call it Schrodinger's cat, for those of you that are physics fans. We don't know if it's alive or dead, or if it's alive and dead at the same time. And the reason I say that is that while we're fairly confident that Assemblywoman Paulin, who is, of course, represents most of you in Westchester County, we believe that she put this in, under her control so she could control the bill. But truth told, she did have a press conference with Senator Rivera over the summer. They did talk about how they had worked with at least the public sector unions to try to get this to a point where they would accept the bill. And we don't know what would happen if the Senate has enough co-sponsors, frankly, to pass the bill just based on co-sponsors. We don't know what would happen if it were to pass in the Senate, what kind of pressure would be brought to bear on the Assembly. So, while I don't, I don't think that this is something that we think is really going to pass or get signed this year, that is not something that I can say 100% as fact. There is a ton of opposition to the bill for some of the reasons that were mentioned earlier. The opposition comes from business groups. The Business Council of Westchester and the New York State Business Council, where I formerly worked, we were leading the charge in business opposition, that us and other groups, for a number of reasons that Bill will talk about in a moment. But it wasn't just us. I mean, it was labor unions, and it was retirees of public sectors, and it was medical groups, and it was hospital groups, and others, and pharmaceutical groups. There was just broad opposition to the bill. Some opposed it for the specifics of their sector. Some opposed it for the economic problems that it would make, and some simply because they believed that this system would create a healthcare system in New York that was really far worse than what we had today. There have been steps along the way, incidentally, to try to close that gap that I mentioned before, that 800,000 people who are without coverage. A couple of years ago, we saw the passage of Coverage for All, which allowed for the purchase of the essential plan by undocumented people in New York. It was not a total coverage, but as I said, every day they continue to work on it. And then the last little bit of history that's worth mentioning is how single payer has sort of played in the United States generally. And so when you look at New York's health plan, when you look at this bill, and you see that it completely outlaws private insurance, and turns everybody into this public system, it is not that much similar to some of the other sort of single payer, or I should say sort of state sponsored systems throughout the world. If we look at the UK and their national healthcare system, or you look at Canada and the various provinces and their socialized system, those are actually private and public insurance systems working together. The more public ones seem to be sort of collapsing in on themselves, actually under the weight of the expense of those systems. But this one is different. The one that we're proposing in New York would outlaw all of that private insurance. It would be more akin to what we saw in places like Belarus and Cuba. It really is a really draconian kind of approach to healthcare, or health insurance reform, I should say. So other states have sort of seen it. They've taken a look. Colorado had it on a ballot at one point. It was defeated almost 3-1, if I remember correctly. California, and they're talking about it again in California now, but the last go around in California a handful of years ago, when they saw that the price tag was going to be well over $400 billion a year, they pretty immediately walked away. In Vermont, Peter Shumlin had essentially run on a single payer platform and said, this is something that we must do and will get done. It passed, and when they started to investigate implementation, they realized that it would essentially destroy the state economically. So it was something that they had to walk away from. That's a state that has roughly, I don't know, 4% of the population of New York, and it was going to be too expensive to do it there. So it's been really sort of interesting over the years when you see that we started it with a bill that was put in because there weren't enough New Yorkers insured, and we've moved into a paradigm where many more New Yorkers are insured. There's still this endless push for the bill. So it seems to be, in many respects, a solution searching for a problem. And we know that there are a lot of other ways to get to completely universal coverage without completely upending this system, and subjecting us, the state, our businesses, to the fallout that Bill will talk about now as he summarizes the bill and talks about some of the issues with taxation and so forth. Happy to answer questions about that first piece at the end. Please submit and we will get there. Bill?
Thank you, Lev. Pleasure to be here. So I thought I would start by talking about the mechanics of the legislation. It seems obvious, but there would be one state-run health plan managed in Albany for every single resident of the state, 20 million people, including people who are not here, who are not citizens, so undocumented immigrants. That raises the tricky question of how you define resident. The bill just sort of says a person who can, for whom New York is their primary abode, but there's no specific residency requirement. You don't have to spend a certain number of months or years here. And it also defines residents as people who may live in another state, but who work full-time in New York. And so it's actually more than 20 million people who would be covered by this. It would pay every last dollar of every medical bill, including long-term care, which most insurance does not cover. So nursing homes and home care. Providers would not be allowed to accept any other payment except what the state pays. That's a departure, as Lev was indicating. That's one of the many ways in which this departs from single-payer systems in other countries. In other countries, there's still the option of private insurance or directly paying your provider. In New York, that would not be legal. There would be all of the money for this would come through the state and through taxes and through other sources of government funding. There would be no premiums or copays or deductibles. There would also be no prior authorization and no physician network. So theoretically, you could, at any time, you could go to see whatever specialist you could get an appointment with. The bill specifies that it should be financed with two particular taxes: a payroll tax, which would be split 80-20 between the employer and the employee, and a non-payroll tax. So that's tax on any other forms of income, which in New York's case would be mostly investment income, business income. As Lev indicated, I just want to reemphasize, this is the more extreme plan than you see in most other parts of the world. It also leaves a lot of blank spots, a lot of things that it leaves to be determined later, either by a future legislature or by the governor or by a panel that's created under this bill. And those questions are pretty big. I mean, it's a single payer plan, and one of the questions that isn't answered is how much it would pay. There's no it just sort of says, we'll pay providers a reasonable amount, but it doesn't say, will that be more than Medicaid? Will it be less than Medicare? Will it be as much as what commercial insurers pay now? It probably couldn't be that. So because we don't know how we're going to be paying providers, we also don't have a good idea of how much it would cost to do this. And because we don't know how much it would cost, we also have only a dim idea of the impact it would have on taxes. So a few years ago, one of the criticisms I've had of this whole process is that the state was going into this without a clear idea, without sort of gaming it out and studying what the economics of it would be. The New York Health Foundation, a semi-private organization, kind of filled in that blank and commissioned a study by the RAND Group, a think tank. And that study made a bunch of generous assumptions about how efficient this would be and whether the federal government would cooperate. And so I would say this is a kind of best case scenario for how this plan would work. But it's pretty much the only game in town in terms of a thorough assessment of cost, and also they went to the trouble of kind of coming up with hypothetical tax rates, and that would provide enough money, and which I'm now going to use to give you an idea of what the tax impact would be. The price tag they came up with initially was 139 billion, but then very quickly it jumped to almost 160 billion because the authors decided to cover long-term care. Again, I think this is a best case scenario. And that 160 billion, by the way, is just the additional tax revenue that the state would need. It's assuming it would use all of the existing tax revenue that goes into healthcare, both state and federal, would continue to be part of the system. So this is an increment above what we have now. So I'm going to share my screen here. I'm going to try to share my screen. Okay. So these are the hypothetical rates that the RAND Corporation came up with. The bill specifies that people at the low end of the income scale shouldn't pay anything towards this. RAND envisioned a tax rate for kind of the broad middle class from about 27,000 to 141,000 of income. That tax rate would be almost 13%. Again, it would be split 80-20. The employer would pay most of it. So there's part of your impact on business. I think economists would tell you as a practical matter, that's coming out of compensation. So it's affecting the employee too. And the rate for the upper income group would be over 25%, and there'd be similar rates for non-payroll income. So these are the tax rates that exist now, the income tax rates that exist now in New York. They go from, as you can see, they go from 4% at the low end to almost 11% at the very high end. Most of us pay between 6 and 7% of our income in state level income taxes. So this is what it would look like if single payer passed. Or there we go. So the bright red is the part that the employee would be responsible for. The lighter pink is the employer share. So just the bright red is about a 50% increase in your taxes. And then if you include the employer share, you're talking about more or less tripling your taxes at the middle income level and quintupling them at the high end and getting close to 40% rate of taxation. This is the same analysis for the non-payroll tax. Again, very high rates. So this is a common benchmark of how heavy the tax burden is in New York, is to look at all state and local taxes per capita. Right now, we're about 10,000, and that puts us at the very high end. Each of these bars is a state, and New York is it's the one second from the right, just behind the District of Columbia. If we did single payer, that burden would double. So you'd go from almost double. It would go from 9,000 to almost 18,000. And this is another comparison by state. This is the top marginal rate. Now, this is the rate that's paid by the very richest people, and so it doesn't affect that many taxpayers, but they're an important constituency. Quite a few of them live in Westchester County, I would imagine. And they spend a lot of money in the economy. They invest a lot of money into creating jobs, et cetera. But they also pay a lot of taxes. And so they're important to our tax base as it exists now. They're providing a lot of the resources that we use for education and roads and public safety and everything else. So New York State is the second to last bar on the right, and New York City is the last bar. And you can see New York City is the highest in the country among the states that have an income tax. And this is what would happen if single payer passed. We would go into a whole other dimension in terms of our competitiveness with other states. The residents of New York State and the residents of New York City with high incomes would be expected to pay almost 40% of their income to the state, with a lot of that going to healthcare. So a point I would make in this context is it's called the New York Health Act, but it might also be called the New York Income Redistribution Act, because that, as Lev indicated, we've made a lot of progress towards universal coverage. And most of the people who aren't insured right now could sign up tomorrow for either free coverage through Medicaid or the Essential Plan, or heavily subsidized coverage through Obamacare. They're not covered in part because many of them have just chosen not to take advantage of those programs. There's a pretty sizable group of people who aren't eligible because of their citizenship status or their lack of citizenship. And that's kind of a whole tricky issue of itself. So this bill would not, it would add to the number of people who have insurance, clearly. But that's a relatively small effect compared to what it would do to the tax code, as we've just seen. You will hear supporters of this bill say that 90% of New Yorkers will save money. I mean, first of all, that's kind of speculative because we don't know the cost and we don't know the exact tax rates. But even if you assume the tax rates that Rand came up with and that I just talked about, the reason that anybody saves money, it's not because the system is cheaper, it's because you've redistributed the cost farther up the income scale. So the very rich under this scenario would be subsidizing almost everybody in the state to pay for their health insurance. It would be and that's assuming that, okay, so one last thing before I turn it back to Lev. Rand did not attempt to estimate how many taxpayers would leave, but they did give an analysis of what would happen if people did leave. And they said if 0.5% of taxpayers left the state at the high end, so the very wealthy taxpayers, if 0.5% of the wealthiest taxpayers left, that would cost the new healthcare system $31 billion. And so they started gaming out how much higher the taxes would have to go to cover that $31 billion loss. And you get a spiral where in order to cover that loss, the tax rates go up, more people leave, the tax rates go up. They did talk about in there the possibility of what they called tax-based collapse, and that would have effects beyond the healthcare system. That would, the whole economy and certainly everything, all the revenue of the government would be affected by that. So now I'll turn it back over to Lev.
Thanks, Bill. Just a couple of
Did I
points.
turn off my share screen?
You did.
Did,
Okay, good.
you're good.
Just a couple of points on the RAND study. It was a number of years ago already that RAND did this study, and it actually predated the addition to long-term care in the New York Health Act. I think it would significantly increase the costs compared to what were estimated at the time, and they were estimated at $250 billion a year. So we're probably talking about a really significant, not to mention all the inflation we've seen since then. So we're talking about an annual number that probably dwarfs that $250 billion mark. And there are a lot of I see some questions popping up. I'm not going to address them all right now. We have time for that at the end, but some of them I was about to address anyway. The bill makes or the proponents make a lot of assumptions of savings. There was a study that came out of the University of Massachusetts from a very friendly professor who was a proponent of the cause that made really, really interesting and pie in the sky sort of estimations on what the savings would be here. The RAND study, making certain assumptions, had very, I would say, modest savings in the out years, about a decade away. I think that those would probably be eaten away by the long-term care addition. but there are a lot of assumptions of savings, and most of them, frankly, are built on, we're going to do away with these middlemen. We're going to do away with for-profit insurance companies. We're going to do away with all these things. They don't take into effect a lot of things, including at very least, regional not-for-profit health insurers. They don't take into effect the job losses that would be practically immediately put into place, which are estimated about 160,000 job losses. Obviously, many of those are in the insurance sector, but even more are in the finance sector, are in the service sector, boiling right down to even like the lunch shops, sort of in the areas where people do business. That's more jobs than we lost in 2007 and 2008 during the recession. It would be a traumatic impact on the state, in addition to all of the taxes. One more thing I would add to what Bill said: the new version of the bill has basically one additional change that is a giveaway to municipal employees. And what it does is it exempts them from their share of the payroll tax. So in other words, the rest of us who work and are on payroll will be paying our 20% of that payroll tax. Our employers will be paying 80. But if you were a state or a municipal employee, you will not be paying that. That will be absorbed by your employer. So that also is an additional burden, pardon me, on the rest of taxpayers. So it really has become an even more unfair sort of proposal when you take that into consideration. There are a lot of assumptions that, I guess the best way to put this is, you have a bill that gives everyone everything, and then makes the claim that it's going to save money. I mean, we all know that resources are tremendously finite, and the bill allows for collective bargaining of healthcare providers. So you have this situation where you're going to essentially form doctors' unions to negotiate with the state on their rates. And our assumption from that is that they're going to negotiate lower rates than they have today. It's a nonsensical kind of assumption. But even if they were successful in bringing up rates, which perhaps they would be successful at, you would end up with this leveling off of sort of what providers are paid. So, we all know that health plans negotiate with providers, and there are some providers that are, just like every other field, some providers that are better than others. There are some hospitals with better outcomes, some specialists with better outcomes, people who demand higher pay. But in a system like this, every neurologist, every neurosurgeon, every cardiac surgeon would be receiving the same rate for the same procedure. So what you would see most likely, and I know that somebody sort of asked this, is that these are people. This is not a national plan. This is not a system where someone, and I think it was Jamie that said that people in Westchester go to Connecticut to see specialists, to see doctors. Well, there's simply no reason that a doctor practicing in Westchester wouldn't realize that if his income could be significantly better by driving 10 miles and practicing in Connecticut, there's simply no reason we wouldn't see that drain of really high quality physicians and other providers out of the state. So the assumption of savings there on this collective bargaining, I think, is really, really difficult to sort of swallow. Also, it's not unlikely, to what Bill alluded, that if we were to lose or even a small fraction of very high yield taxpayers, that those of us sort of in the middle class would be left picking up so much more of the burden. And I think Bill once said to me, this would really be a story about redistribution of wealth from one group of the middle class to another group of the middle class. And I think that is profoundly true. The other assumptions that are sort of involved have to do with the problems of implementation itself, some of which were alluded to earlier. Bill mentioned federal dollars being included in this. Well, that includes Medicaid, and we would have to get a significant number of waivers from the federal government to use Medicaid dollars in this way. That's absolutely no guarantee that that would happen under any administration in Washington. And we know administrations in Washington change and their policies change on this. So that is far from a guarantee. Also, it assumes the assumption of Medicare dollars from our retirees who are in the Medicare program. It's pretty much black letter law now under many court cases that Medicare benefits don't belong to the state wherein somebody lives. They belong to the recipient themselves. So it's highly unlikely that we'd be able to transfer those Medicare dollars into this program. And we would continue with these competing systems. Thirdly, there's been a study also on the impacts on ERISA. And I know that somebody had a question about that, about, companies that maybe operate in multiple states, companies that insure their employees across the board and across the country. Maybe they do it under collective bargaining agreements. Maybe they do it just as general practice. What they would end up being subject to is they'd be subject to this payroll tax, this immense payroll tax. But they would still essentially have to offer their employees in our state their own private coverage, which they wouldn't be able to actually administer because the physicians in New York State wouldn't be able to take that product. So you'd be instituting this, lack of a better word, double taxation on these companies. And it's most likely a violation of ERISA, which is of course the federal law that dictates around those kinds of private insurance plans within companies. So there are all of these hurdles, not the least of which, of course, in my mind, some of them are economic, but some of them are very practical. And the chasing away of providers, I think, is one of the things that really hasn't been paid that much attention to or enough attention to, and the quality of care that we'd be receiving in New York. If you look at wait times in the UK, if you look at wait times in Canada and some other states, they're pretty abysmal for care. Ours, in certain specialties are not so great either, to be honest, and could certainly get better. But we'd be trading it in for much worse. And in fact, and the statistics have of course changed, and COVID has made things a little murkier. But if you live in Canada, and this was a statistic from 5 years ago, but if you lived in Canada and you had a neurological emergency, out of the 35 that had occurred in that year that needed immediate attention, they were all brought to New York or Michigan. It just isn't a system that was really doing a great job of sort of taking care of the outliers. And the proponents of the bill tend to look at these countries with awe and these systems with awe and say that this is what we want. And unfortunately, I think what you would end up with on the quality level is perhaps a more equal system than we have today. There's no doubts that our system has some faults, but it would be more equal because all of us would be, or many of us would have worse care, lesser care, and longer waits. So these implementation issues, I think, are very real. And also, how do we continue functioning were the bill to pass, and it would take several years to implement? How will we continue functioning when we're looking at health insurance companies that we will be legislatively putting out of business, and we will be saying to them, we'll keep functioning now for a while and jumping through our hoops and putting up with endless regulatory schemes, but 3, 4, 5 years from now, goodbye. It's not a particularly it's not a scenario that sort of would breed success. So that, those are some of the other problems. The one thing that, before we go to other questions, I actually have a question for Bill, because I know you can answer this better than I can. So
Hope so.
Westchester County in particular is a county with pretty significant property taxes, as many of us, our upstate counties throughout New York have. And I know that Assemblywoman Paulin had made a comment, at least during the press conference when they introduced the new version of the bill, talked about how this would help out with property taxes. I know that that argument has been made by some others. I also don't believe that it holds a lot of water, but I just wanted to ask you quickly about that, a little insight on that, before we got to the other question.
I mean, the local government pays for healthcare sort of two main ways. One is it buys health insurance for its own employees, and that whether that turns out to be a savings or not would depend on exactly how the tax code is written, which we don't know. Under the RAND scenario, my guess is that the tax rates that they talked about, given the pay levels of most public employees, that the tax rates they're talking about would be roughly the same as what they're paying for health insurance, maybe a little bit lower. But again, that depends on higher income people subsidizing their insurance. And then the other big way that local property taxpayers pay for healthcare is in New York State, the counties have to contribute towards Medicaid. I believe the sponsors of the bill have been quoted indicating that would go away, but it's only going to go away because they're going to raise taxes somewhere else. In this case, they're going to raise taxes on income. And I think Westchester, there are certain counties where that trade-off would be very undesirable, where the impact on the income of the residents, if you tax their income, would be higher than the savings on their property taxes. That's not going to be true necessarily for a low-income county upstate, but for a high-income county like Westchester, the trade-off would be a net negative for their residents. I guess another thing to remember here is that RAND scenario is kind of a snapshot in time. They were trying to project forward to what things would be in 2022, which is already now in the rearview mirror. But the reality of healthcare is that the costs go up every year. And if the entire healthcare system is part of state government, a normal amount of inflation would result in $10 to $20 billion increase in costs for the state. And they would have to figure out, well, how are we going to get that additional money? Another problem is that our tax code is subject to booms and busts. Already, when there's a downturn on Wall Street, we end up having a fiscal crisis in Albany. That fiscal crisis would be 2 or 3 times worse if you're also taking responsibility for the whole healthcare system. I think we should probably go to questions at this point.
Thank you both. I think for everyone on this webinar, I hope now has just again a better snapshot of what the impact can be for this. We have a few questions. I'm going to try to get to them. I'm just going to start off though with a question. Look, as you both have said, the history of this bill started with the Assembly. The Assembly was in the majority. The Senate was in the Democratic Senate was in the minority. So for those of us who were involved in this, we always considered single payer a one house bill, so to speak, because of the fact that it could pass the Assembly with the majority, but it wasn't going to get passed in the Senate. Well, the political landscape in Albany changed dramatically a few years ago when the Democrats took control of the Senate. So now any one house bill that anyone thought wouldn't pass the Senate now becomes a live 2-house bill. So here's my question. Lev, you said something in your earlier remarks that the look of this bill is to try to find a solution searching for a problem. With everything that you all have just laid out for us today, with the fact that the New York Health Exchange has already enrolled 95% of the people in New York who needed health insurance, where is the disconnect? Because obviously Senator Rivera and other proponents of the bill are not looking at the fact that we have moved in hopefully a positive direction to get those folks who we wanted to get healthcare insurance for themselves and their families. But the fact that they also must understand what the fiscal impact could be. So as you're talking to legislators on both sides of the aisle in both houses, is there a recognition that it's great to be able to say we pass single payer, but then what would be the, not only the unintended consequences, but what would be the real fiscal impact for New York State, especially if we're looking at deficits in the out years?
It's an interesting question, John, and there's a couple of answers that I could give you. There are some legislators that are co-sponsors, whether in the Senate or the Assembly, who have said to me privately, and some frankly have said it publicly, in forums, that they are proponents of this bill simply because they are proponents of single payer on a national level. And they recognize that if you were to do it on a single state level, it probably wouldn't work, but their way of sort of lending support to the national conversation is by sponsoring this bill. So there's a population among the legislators who recognize that this is impossible, that this is just a devastating proposal. There are others, I think, that simply just don't know any better. And then there are some that are true believers for whatever reason it is, and they bring it up as a solution for just about everything. We hear Senator Rivera bring it up at every hearing, at every health committee meeting, and whenever there's a bill trying to correct some marginal issue in healthcare, he brings it up as the solution. I've had conversations with legislators in one of my old hats when I used to do a lot of workers' comp work, who every time I brought up a problem in the workers' comp system would say that's why we need the New York Health Act, because that would do away with workers' comp, and it would none of these things hold a lot of water when you sort of dig under the surface, obviously. The disconnect is not just on this bill. I think that as you fight for businesses in this state, that a lot of times legislators have a hard time sort of seeing both sides of the ledger. They see the proposed benefits of any given proposal, but they tend to fail to see the costs and sort of some of the cost consequences. And those blinders, I think, are sort of across the board, and they certainly exist here. So.
Well, we're going to have to continue to be diligent, and obviously our opposition to this bill will be part of our 2024 legislative agenda that we will be sharing with all the elected officials, not just in our Westchester delegation, but throughout the legislature. We have a few questions that I want to try to get to because we're running out of time, and any of our two panelists can answer these if they feel so. What is the tax consequence for solo entrepreneurs? And we at the Business Council are very proud of the fact that we have a large number of solo entrepreneurs, but how would they be affected in this?
I believe that would come under the non-payroll tax. I mean, unless they're paying themselves a salary, but the capital gains, investment income, any income that's not payroll income would be subject to that non-payroll tax, which has roughly the same rates as the payroll tax, except there's no employer share. It's all from the business person.
Another question is, why not implement a high-risk pool similar to car insurance instead of undoing the private insurance industry? And as for people who cannot afford insurance, doesn't Medicaid already provide coverage?
The answer is, well, to the first part, the specifics of a high-risk pool, we have a lot of different kinds of coverage, publicly sponsored coverage, things with federal subsidies, things with Medicaid, and the things that go well beyond the Medicaid poverty level. We already have most of those things, and as Bill alluded to, the vast majority of the uninsured are uninsured either because of complications with immigration status, or simply they just haven't signed up for a program that they would already fit into.
If a resident had a medical emergency out of state, would this plan pay for the medical bills that they would have?
The plan says that it would. I mean, that's kind of the same situation you have with retirees. Somebody who worked for the state, moved to Florida. They currently depend on state-sponsored insurance. What would happen to them? The plan says it would be able to pay for providers out of state. The thing is, with providers in state, it has more leverage. It can set the rates, and it can require them to accept the rates if they're going to live in New York. With providers out of state, it would have to be a negotiation. I mean, insurers do that a lot. It's just that you might get a situation where the state is paying providers in other states more than it's paying providers in New York. And I think this is a particular issue with tax flight, because one group that would be in that high tax bracket is most physicians. So they would face kind of a double whammy. If you're a very high end, say you're a neurosurgeon or something, you would face a loss of income because of the flattening effect. You would be paid the same rate as every other neurosurgeon in the state. And you're facing dramatically higher taxes under this. I don't see why you wouldn't move out of state under those circumstances.
Well, then, and another question that someone asked, and I think Jamie, actually, you touched on this too. What would prevent physicians from leaving New York State to practice in another state? So there'd be a drain in terms of the quality healthcare that we want to have for the folks in Westchester and New York State.
We have a single payer plan in New York when you look at Medicaid. And we have problems with providers within that system that don't want to take the rate that Medicaid pays because it's significantly lower. So while these are not people who've had to move, they're just people who simply don't take that insurance. We already see that at play. So if you were to sort of expand that to the whole state with lower reimbursements across the board, the only other answer, the solution is it's not about I'm not going to take the insurance. It's I'm just not going to practice here. So it's we sort of already see it playing out to a certain degree.
Jamie, did you want to add anything?
Yeah, I was just going to add, and that's my comment I made earlier. That's where the commercial market kind of levels out the payment structure, because they're paying at a rate that's significantly higher than Medicaid, right? So I think, and I agree with Lev that you do see some doctors that may want to opt out or not practice, or limit their practice, but the commercial market is really kind of where they're going to break even, or make a slight profit. So if that's removed, and I don't believe Lev or Bill, are there any details in terms of provider reimbursement in the bill?
No, that's a big gap in the bill. It doesn't like often a health plan will say, we will pay you the Medicare rate plus 20% or something like that. There's nothing like that in the legislation. It says reasonable and adequate. And it provides for providers to form negotiating organizations, similar to unions. And I think if you look at the dynamic in Albany politics, the most influential groups in Albany are the healthcare providers and the unions for healthcare workers. And they've become very adept at getting the state to give them more money. And that's just through Medicaid. If Albany was in control of every last dollar that was paid to a hospital or a doctor, they would take their lobbying up to another level, because every bit of their income will be dependent on decisions made in Albany.
We have time for one last question, and I think we touched on some of this, but we'll just we'll ask it for you guys to just give us a final thought on it. If the bill is to cover long-term care, what does that do for those of us who have been diligently paying into private plans?
It does the same thing of those of us that paid for college, and if college becomes free. One interesting thing is, I'm not sure that the plan even anticipates that, because it says that they can't collect from a private insurer. I suspect that if this, God forbid, ever became law, that would probably get amended, simply because they would take the opportunity to take those private dollars that have already been paid for. But the other point about long-term care, I think that's so fascinating, is were this to pass, I would leave New York State, I would go live somewhere warm, and then when it was time for me, if I ever needed long-term care, I would come right back to New York, because I would become eligible for it the minute I crossed the border, and it would be 100% paid by the state. Since we're running out of time, and I will, of course, thank you to all of you for allowing us to have the forum, but I also just wanted to end with this. Folks in Westchester County, I think, have a specific responsibility and an opportunity, because Assemblywoman Paulin is in your district. I think that it would behoove the folks on the webinar today and folks in the community to reach out and just let her know. You know, she is a very, very smart legislator. She understands these issues, but just let her know how devastating, you know, that you think that this would be to your business, to the health system in New York, and our tax structure in general. I think it's just an important takeaway and be much appreciated, certainly on our end.
Well, and I appreciate that comment. And yes, we have a good working relationship with Assemblywoman Paulin. One of our tools that we use in our legislative advocacy program is something called Voter Voice, which allows us to create a message to then send to our members. And all our members have to do is literally put in their zip code and an address and zip code, and that message then goes to their state assembly member, their state senator, and to the governor. And obviously, as we go through this legislative session, and if this bill continues to move forward, we will definitely be reaching out to our entire membership, asking them to participate in this effort to reach out to Assemblywoman Paulin and their assembly members and state senators and the governor as well. I want to thank our speakers. I want to thank our board chair, Jamie Schutzer, again, who is a senior partner at JDM Benefits and the Lara Group Company, for his ongoing leadership in helping us in this advocacy effort. And most importantly, I want to thank our two guests today, Bill Hammond, a senior fellow for health policy at the Empire Center, and Lev Ginsberg, a partner with Hinman Straub, and also the executive director of the New York Conference of Blue Cross and Blue Shield. This is an issue that we will continue to focus on. This whole entire webinar has been recorded. It will be on our business resource page at the BCW website, www.thebcw.org. Please feel free to share this webinar with colleagues and with clients who might be interested as well. And I wish everyone a good weekend and stay well. Thank you all for tuning in.
Thank you, John.
Thank you.
all.